Good evening to all the aspirants present here. Today's topic is acute coronary care. It is class 3, and the speaker that we have here is Dr. Sangshaptak Saha. He is an associate consultant critical care medicine at Apollo Hospital, Kolkata. Thank you, sir. So you may take over.
Yeah. Acute coronary care part, and today, as I discussed in the last class, that it will be basically a practice session for the MCQs, solely based upon cardiology. In the first class, we discussed about acute coronary care, the AMI part, and the acute coronary block, those things. And we discussed the two MCQs and mostly two ECGs at the end of the class. The second class is more focused on pericarditis, myocarditis, and cardiomyopathy. So today we shall be discussing mostly about cardiology in the MCQs. I shall be sharing around 25 MCQs, and one of you is answered, and then we shall discuss about it. So I will be sharing this screen, and for each one of you answer and read out the question and answer. Then we shall discuss about it for a few minutes, and we can move on to the next question. Somebody can volunteer and answer. Details on chat box. Okay. So is anybody volunteering to answer or?
Most.
Yeah. So 76 years old woman was in the acute medicine follow-up clinic. She has been admitted with palpitations, but at the time of admission, her respiratory discipline showed normal sinus rhythm. So she had these episodes a few times also before, but they always reverted spontaneously. Significant past medical history was not present. An outpatient 24-hour ECG was performed which showed 10-minute turn of air. The patient did not feel palpitations at this time. So what is the first thing management? So basically an arrhythmia patient who had previously also had similar episodes. Now she is having a 10-minute turn of air and the patient did not feel palpitations at this time however. So it was asymptomatic. So what will be the first thing of management? So there are 5 options. So if one of you can answer that, let's try to answer and we will discuss about the correct answer. Okay.
All the aspirants are requested to kindly unmute the mic and please uh, do initiate in the class.
Yeah, because then it will be an interactive class. Otherwise, like, I can also share the answer and discuss. Okay, first one I shall discuss and maybe others will join in the next one.
Please take an initiative. It's an interactive Q&A session. It is a helpful session for all. Thank you.
So basically, this is a patient of who is suffering from atrial fibrillation, and previously she had this atrial fibrillation terminated spontaneously. So those were autosomal intermittent because the spontaneous terminated within 48 hours, right? So that is the typical definition. That is the classical definition classification of atrial fibrillation. So that happened, and now the AF is occurring. But we do not know why the AF is occurring or what is the underlying cause of the AF. So because that much information is not being given. So the first option, no treatment is necessary as the AF is short and self-terminating, is not possible here because she is having this recurrent ache. So the first option is not the answer. The second option is fill in the pocket thickeners. Fill in the pocket thickeners is the chronic conditions in which the patient is like the patient is having a continuous ache which was not terminated, or the patient will be chronic ache and they know that it will not be it will not be terminated by the classical medication. They will usually apply. It is not for the ICU patient, so very unlikely that will be the answer in the in the EDIC exam, and it is not the answer here. The third is regular amiodarone. Regular amiodarone is for persistent ache where the patient is symptomatic. Here the patient did not feel palpitation at this time. That is also not the answer. And regular deoxin also is not a first line management drug. As we know, in a 76 years old woman, the first line management will be rate control versus rhythm control. Here, the patient does not have chronic ache, so unlike the persistent ache. So rhythm control is not the question here. Here the main goal is rate control. So we have to go for a rate controlling drug. Which is first line is either a beta blocker or a calcium blocker. So the answer here is a beta blocker. So in this one question, they are testing your knowledge about the classification articulation, the basic management articulation, also whether you know when we are using amiodarone, deoxin, and thickenite. So only after this much knowledge you can go for the option D, regular beta adrenergic blocker. So AF is all like everybody knows that they'll practice 50 questions based on AF, so you know everything about AF. Okay. So this is the first question. So now we shall become the next question, and I want somebody to read the question first, and then I want to answer. It's not an exam, right? So even if you're wrong, then also it does not matter. You can just analyze how you are approaching the question and going for the answer, and then you can take up the explanation after that. I will give you 2 minutes to read the question and then to get the answer. So, students, have you read the question and like if somebody ready to answer this? So, what are the like persistent points for this question? So, firstly, the patient is a hypertensive patient with ischemic heart disease and had a previous history of myocardial ischemia for which a PTCA has been done, right? This time he has presented with ventricular tachycardia, which was hemodynamically unstable. So hemodynamically unstable ventricular tachycardia and management for that has been given already. So that is not a part of the question. Here undergone DC cardioversion and now he is in sinus rhythm. Troponin T was raised and it was rising after 12 hours. So there is a cardiomyopathy because of the VT probably. And echocardiogram shows a LPF with a low ejection fraction, and there is also like an anterior hypokinesia. So, what will be the management option for this patient in long term? So, they have asked for a long term management strategy, not a short term management strategy, right? So, long term, what is the management option? Okay, so like you were answering here, so it's option A. Dr. Muhammad and Dr. Dharani has told that it's answer A. Okay. So it's referred to inpatient implantable cardiovascular defibrillator. So that is the answer. So first I shall discuss the other option, and then we can go back to that. So second option is referred for inpatient electrophysiology testing and ablation of VT. So that is not the answer here because the patient needs a long-term ICD. Electrophysiology testing ablation of VT can also be done, but like the VT has already been terminated here, so that is not the answer here. The third option is inpatient PTCA. So troponin T raising here is because of the post-VT patient. So rise in troponin T is not specific for acute myocardial infarction. It can happen post-VT and the post-shock. So we have to have the information and rule out option C. It is not an AMI. Option D is referred to the cardiology outpatient department for assessment. So again, that is a vague option, and like common sense answer that will not be the answer here. And option E is long-term amiodarone. Long-term amiodarone is chemical cardioversion. Chemical cardioversion is not the answer here because ICT has got long-term mortality benefits, which like better outcome than amiodarone. That is why we are going with the option A here. Somebody is confused with what is the option here. Option like question of previous question. So here the answer is regular beta adrenergic blocker because the patient needs a rate control care, and then we have to analyze the patient, further test the patients, and then we can go for the amiodarone or the dioxin the second eye. Not right now because that much information has not been provided here. So the option D is the answer. Okay. So this is the third question. This is showing the ECG. So 34-year-old woman presented with palpitations. Recently, she has been posted for ablation and she has been included by the electrophysiologist. She had tried the crossover maneuver, did not work. Vehicle maneuvers, no effect. Heart rate 200, blood pressure is stable. So she is not hemodynamically unstable as of now. This is the ECG. Analyze the ECG, and then I can show you the options and we shall discuss. Okay. I think the ECG was is a straightforward diagnosis. Can somebody tell me what is the diagnosis on the basis of the ECG? Write it on the chat box while I share the options. So, okay, doctor. Her name is Dr. Neji, NEH. You have written that the answer is what have you written? You have written that the answer is PSBT. PSBT and treatment is adenosine 6 milligram. Why do you think the answer is PSBT? I mean, why do you think the ECG is showing PSBT? Let's refocus on the ECG once again. I mean, the ECG is clearly showing that it's an irregular heart rhythm, right? I mean, there's no doubt about that. See, this is the RR interval. This is the RR interval. This, again this. So it's an irregular rhythm, right? So the diagnosis is, I mean, the diagnosis is irregular. The diagnosis is A. I hope there's no confusion about that because I mean, yeah, if there's confusion, first you have to diagnose the patient based upon this because they have not given, they have mentioned that the cardiac electrophysiologist was there and they are awaiting an for ablation. They have not given a diagnosis, and so they have also mentioned that the vagal maneuver Valsalva was not worked because it's an ape, right? It will not work. So now, what is the answer? I think other candidates are also mentioned as option A for some reason. Okay. Guys, like you have to diagnose that it's an atrial fibrillation first. Okay. Intravenous adenosine, I don't know why you're telling intravenous adenosine. It's intravenous adenosine is a treatment for PSBT. And it's not a PSBT, it's an AF. So yeah, it's intravenous amiodarone, which is a standard treatment for AF. I think everybody who I think the first step is to diagnose the AF first. And then the answer is, I mean the answer is quite obvious. It's intravenous amiodarone. Right? Because like yeah, adenosine you have ruled out. Adenosine is not adenosine because it's not a PSBT. Dioxin is not a first treatment for AIDS. Metoprolol, Verapamil, yes, those are also good drugs. But in this case, the heart rate is 200 and the blood pressure is 140 by 80. And it's here we require a chemical cardioversion, right? Because the electrophysiologist is already seen the patient and they're waiting for an ablation. What does that mean? Ablation means that there is an extra pathway, and so the word here we need to go through the aid. The second part is knowing that the patient is planned for clinical cardioversion here. You see, there are three parts. You have to know all the three parts to reach the diagnosis and the option. The diagnosis is if and the patient needs. I think you need to check your internet connection. Those who are having poor sound quality. Mine is running at a speed of 110 ms. Anyway, the obstetrician team asked for a medical opinion. A 32-year-old woman was being treated for gestational hypertension in laboratory. She had delivered a baby boy 3 days previously. Was not breastfeeding. Her blood pressure was 155 by 105. The obstetric team was concerned that her blood pressure has not reverted to normal levels following delivery. What would you advise? So first tell me what the diagnosis here. Gestational hypertension, 32 years old on labetalol. Now she had delivered baby boy 3 days previously. Blood pressure not reverted back. It's still high, 105, right? Okay, right. I screen also. So if you are seeing that, just write it down instead of writing somewhere really poor. Write on the diagnosis. I think others are seeing the screen quite well. Write on the diagnosis because yeah, if the sound is poor on your end, then that can be a problem. Write on the diagnosis. 32 years old woman treated for gestational hypertension. Now the BP is still high. So what is the diagnosis here? So people, let's clear something out. Is my screen visible or not, and am I audible or not? The others, if anybody can see my screen, the candidates, please write
Yes.
down whether you can see my screen, whether you can hear me.
Sometimes it's we can see the screen. Sometimes it's not. It's not static.
So when you were reading your case, we couldn't see the screen. So we are behind on seeing your vignettes and being able to
Can you see
answer
the
the
screen
question.
now?
Now we can see it.
Now we cannot see.
I am changing that. Look, one person can see the screen, so I think then the problem is on your end because the other person has told that she can see the screen.
Can perhaps the host help us out here so the screen comes on and off? Yeah.
When you are checking your SMS, your screen share stops. Make it simultaneously, or we can. The screen will not be interrupted. Okay. Thank you.
Uh, Hello, sir. Sir, the
Mm-hmm.
screen is visible. It's a request to all the aspirants to, when you are answering, please unmute your mic and answer, because seeing the Zoom messages is like quite being difficult for the faculty. Okay, thank you. So you may continue.
Okay.
Here the answer is A.
Anyway, I shall just discuss the answer. Yeah. So it's a case of gestational hypertension and like preeclampsia, and the answer obviously is A. The others I think are quite straightforward. Serum aldosterone levels should not be needed here. Methyl dopa, 24 video collection for caterpillar mice, and those are the options for the other diagnoses which are not there. So here a 25 years old Somali woman who was 38 weeks pregnant was admitted to the acute medical unit with lethargical breathlessness. She has been well throughout her pregnancy and was taking no regular medications. On examination, her temperature was 36, pulse was 100 beats per minute, blood pressure was 110 by 70, respiratory rate was 25 breaths per minute, oxygen saturation 94%. On auscultation of her chest, there was palpitations to the middle zones bilaterally. Abdominal examination was consistent with pregnancy. What medication regimen should be set for this patient? So once again, a question from pregnancy. So usually there are a couple of one or two questions in EDIC based upon cardiac conditions in pregnancy. It's either a microstenosis or a pericardial cardiomyopathy or a gestation hypertension, eclampsia, cardiovascular.
The answer is C.
Woman, 38 is pregnant, 25 years old, young patient, uh, and now at the end of the pregnancy, here the breathlessness with the diabetes. Some palpitations were there. Abdominal examination was the pregnancy. So the pericardium cardiomyopathy and with heart failure status. So what medication to say? So firstly, you have to reach a diagnosis of the pericardium cardiomyopathy, and then you have to know which whether you know that the ACE inhibitors and ARB are contraindicated in pregnancy or not. So moving on to the next question. 75 years old man, the hysterectomic heart disease, admitted to acute medical unit with chest pain and collapse. He had a myocardial infarction 10 years previously and single drug stent was given to the lady. On examination, right now he is okay. Like the blood pressure 100 by 70, 60 beats per minute is the pulse rate. Loud ejection systolic murmur is going to the carotid. But what to prompt to refer for aortic replacement. They have also given the ECG and the echocardiogram. So basically, they want to know whether you know the indication for easy replacement or not. Echocardiography showing that the outage was gradient, the mean gradient is 50 and the valve area is 0.8. So this is a severe aortic stenosis because less than 1 is severe and a mean gradient more than 40 is also severe. So it's satisfying both the indications for both the classification for severe AS. And what is the indication for aortic valve replacement. The indication is symptomatic patients. Angina and syncope is the answer here. Angina and syncope, if any one of them is present along with these echocardiogram features of severe AS, that itself is an indication for aortic valve replacement. Evidence of LPH is not the answer. So LPH happens at all patients of AS. Harshness of systolic murmur is not an answer. Mean radian 20 is mild to moderate AS, and valve area less than 1 centimeter square is not an itself an indicator for aortic replacement. It needs to be present to along with the signs and symptoms of AS also. So the answer is A, angina and syncope. MS, MR, and AS. These three you need to know what are the indications for aortic valve replacement or mitral valve replacement. You know, the others, tricuspid pulmonary, those will not be masked mostly in the exam. I mean, not fascinating. So, 75-year-old woman with permanent AF presented to the acute medical unit blackouts. She was taking bisoprolol 5 milligram daily and warfarin. Her history included an AF ablation procedure 2 years back, but her AF had recurred. So, once again, a question after population. Now, the patient GP had arranged a halter monitoring, basically 24 halter, and it showed a 5-second pause and another 6.2 seconds pause. The symptom I reported also collapse in the shower. So, multiple obvious indications they have given. So, what would be the best management? So, basically, I want to know whether you know the indications for pacing or not. So, yeah. So, just read the question once yourself, go to the options, and I shall discuss in a minute. Okay. I think everybody knows that all of that there are 2-3 markers for these indications for permanent pacemakers. One of them the patient already has, that the patient has collapsed, so it's symptomatic, and the patient also has got this pause more than 5 seconds and 6.2 seconds pause. So permanent pacemaker, they are given two options, set to DDD, set to DDIR. DDD is for dual, that is for atrial ventricular pacing. Here the patient does not need a atrial dual chamber, right? Because the atrial ventricular pacing, both are not needed. The patient has got an AF, so there is a problem in the conduction of atrial ventricle. The ventricle needs to be placed in such a way that all the conductions are not transmitted. So it's or that is a yeah, that is an inhibitory phase should be given. So the answer is B. Permanent pacemaker set to PPIM. So once you once you realize that the patient is a permanent pacemaker, here they're exploring whether you know when DDD is given, whether DDIR is given. And here the indication is DDIR because the ablations, because other atrial conductions, that is because the A that is happening, all of them should not reach the patient's ventricle and should not trigger it. So that is why the mode should be I, that is inhibitory mode. And obviously DD mode should be given. And atria need not be paced here. It is not a DDD. Repeat ablation is not an option here because the patient is satisfying need for pacemaker. Bisoprolol, dependent for ECG, stop bisoprolol, start deoxygen, all management indications for AF. That is not the part of the question here. The part of the question is that the patient has collapsed and needs a permanent pacemaker. Okay. It's a long stem, but this question actually has come 2 to 3 times in the EDIC. That's why I involved here. Just go through it. I shall discuss. But I think it came the year before also. I think, 1999, where they showed that patients who were H. pylori positive, they had a more chance of acute myocardial infarction, early onset myocardial infarction. So just you have to remember this question, because this question, if it will come due to this. If seropositive for H. pylori infection, the odds of early onset myocardial infarction is 1.27 times more compared to seronegative for H. pylori antibody. So with H. pylori, if it is positive, then early onset myocardial infarction chances more than if the patient is seronegative. Just remember this. I'll include this question for this, not particularly cardiovascular related question, but it comes in the editor. Okay. So coming back to more typical questions. Once again, a question on atrial fibrillation. This time the patient has a theta histopalpitation AF with the first ventricular response of 130 beats per minute. He had no chest pain. He had a history of hypertension, diet control diabetes, and was taking ranitidine 2.5 milligram OD. Admitting doctor has given 2.5 milligram bisoprolol and aspirin for A. Aspirin for A. Okay. On examination, pulse rate was little irregular, but rate control. Blood pressure was okay. Now the patient has asked if you need to continue the aspirin long term to prevent a stroke. So immediately once the patient asks this, you need to calculate what? You need to calculate the Chadwick score, right? So what is the Chadwick score here? Somebody calculate it. What is the Chadwick score here? Does the patient have a chronic heart failure, congestive heart failure? Let me just check whether somebody is saying that. Nobody is saying. That's great. So I think everybody knows the Chadwick score. It's congestive heart failure, hypertension, age, more than 75, score 2, recited 74, score is 1, diabetes, stroke, TIA embolisms, vascular disease, sex category female. So if the score is like more than 1, more than 1 or for female, more than 2 for male, then the Chadwick score is positive, and then you have to give an anticoagulant. Here the patient is a male patient who previously has got an AF and hypertension and diabetes, and so clearly the patient score is and the age is 67. So the patient, I think the patient score is around 3. So the patient needs this aspirin to be. So the patient needs an oral anticoagulant. So the risk factor, so the score is 3 because the patient has hypertensive diabetes and the age is 67 years old. And so the annual stroke is that risk is around 3%, and he should commence on an anticoagulant. Aspirin is not indicated specifically for AIDS, right? There is no rule of aspirin in AIDS. So aspirin is antiplatelet, it's not an anticoagulant, and so aspirin, at least for the AF part, is not needed here, but we need an anticoagulant. And since the score is 3, so the risk is 3%. So Chadwick score of 0 is a 0% risk. Score of 1 is a 1.3% risk. 3 is 3% risk. And the score of 9, that is the maximum possible score, that is around 15% risk. Chadwick score is widely used, and you can, like, you don't have to remember every score, but just remember that the 3 or 4 score, it's usually the same percentage risk after the increases. So because option A and option B are same, only the stroke risk is 3% in option A, 6% option B. So if you know the score, it is 3, it is 3%, not 6%. 6% is something like a score of 5 or something. So calculation of Chadwick score required. 77 years old man was admitted to a coronary care unit with a non-esteroid MI. His ECG showed lateral wall AC depression, blood pressure is 180 by 90, and the chest X-ray showed acute pulmonary edema. Serum troponin T was very much increased, and they have asked for calculation of Gray score. So now we are moving on to the scores. You have to remember a few scores, like the Chadwick score, the Hasbled score, which is for bleeding following an oral anticoagulant risk in a or in other cases. And here they ask for the grace code. Grace code is for the Einstein. So we have to know the component of the grace code, and basically they've asked which one they need to calculate the grace code. Grace code comprises of age, blood pressure, heart rate, Philip heart failure classification, creatinine, elevated troponin, ECG changes, it is segment deviations, cardiac arrest or not, and serum creatinine. Here the serum creatinine is in the option, so you have to go for that. So basically, the question will be very similar to this. They will not expect to know the whole the grade score. They will just expect to know that aspirin, beta blocker, diabetes. Drugs are not a part of the grade score. So immediately you can rule out option A, B, C. Option C is not a part because age, blood pressure, heart rate, hips, ST segment changes, troponin changes, cardiac arrest, creatinine, that is the AKI are the part. So they are expecting you to know that much. They are not expecting you to know all the 8 or 9 components of the grade score. Okay. So just the basic idea of the question will be enough to answer this question. The 10th question for the day. An 85-year-old woman attended the acute medicine follow-up clinic. She has been on acute myocardial, she has been on previously with AF. She has a history of gout. Her current medication includes dabigatran, bisoprolol, with quinine sulfate. Her blood pressure tests are all normal. Her ECG showed AF at a range of 90 beats per minute. She has been told by a friend to stop the dabigatran and she was at a high risk of bleeding. So I was just discussing the Hasbred score, right? So this is a question for the Hasbred score. Bleeding in air. So we have to calculate the Hasbred score here. So she's already on dabigatran, right? So why is she on dabigatran? Dabigatran is noble oral antibiotic directly acting to activate operation. So why is she on that? Because she has been on AS med. So her CADVAS score is more than 2, or at least 2. Even without knowing whether she is hypertensive, diabetic, or other risk factor or heart failure status, you can tell this based upon the age and the sex. So she needs to be on an anticoagulant, and that is why she is an anticoagulant. She has not bled at all, right? Blood tests are all normal. So knowing this much information tells you that the dabigatran should not be stopped and should be continued, and the answer will be E. Am I making sense? Let's see if somebody is replying anything on the chat box. Nobody is replying anything. So I think I'm making total sense here. So you have to calculate the chat box score here and know that the chat box score is more than is access to, and you have to remember that it's the high risk of DPT and P, and so you have to continue dabigatran and blood tests are normal, and so no need to stop the dabigatran. So 25 years old woman presented to the emergency department and some signs and symptoms. He is a known okay, a man, sorry. He is a known case of hydrogenic triventricular cardiomyopathy and already has ICD hydrate. ECG showed is moving. Is there any indication which is sexy here? I don't think so. Options right before we are confirming AMI, which is option A. So clearly between option A and option C, the next best step is option C. ICD malfunctioning, and there is a term for AMI or ischemic patients. Option E is serum troponin. I think serum troponin will take some time to come. We can obviously think the serum troponin level also. But echocardiogram will give you an idea about lots of things. Whether it's a pericardial effusion because it's a post-procedural patient, whether it's an AMI defect. So definitely the next best is echocardiogram. In a in a cardiology question, the answer is already echocardiogram. That is the question. I hope all guys you guys got why it's echocardiogram because you have to first diagnose whether it is a AMI or not. It's a basic procedure, and aspirin echocardiogram fundamental can be given only after you have diagnosed AMI on echocardiogram. It's a recent role in the diagnosing pulmonary edema or something like that, but it's unlikely to pulmonary edema to move the answer of an AMI. We'll go to the next question. So it's a diabetic patient who presented with severe retrosternal chest pain in the left arm. On examination, tachycardia is there, oxygen saturation was maintaining, GDP grossly elevated, auscultation, bilateral palpitations, X-ray gallop, chest X-ray pulmonary edema. ECG, I mean, there can't be a more clear ECG than this, right? Yeah. They have given all the features of AMI. The diagnosis is straightforward. So, which of the following is the least useful in initial management of this patient? Dobutamine, furosemide, GT, nitroglycerin, pulmonary catheter, supplemental oxygen. So, which trial is the typical AMI? It's a typical AMI, right? Typical AMI with all the signs and symptoms and ECG changes. It don't need a pulmonary catheter because it has got its own complications and there is no change in mortality and no change in outcomes. Dobutamine, sorry. Dobutamine furosemide you can use based upon the clinical characteristics. Supplemental oxygen, although it's maintaining, you can use. Clearly, option D is the answer. It's the least useful. Oxygen is not needed for this patient. Right now, dobutamine furosemide are not needed for this patient. We need to do a pulmonary angiography and PCI first. Pulmonary edema will respond to that, not to the furosemide first. But yeah, we can give it a try. As definitely there is a role here. Pulmonary catheter and for the back muscle as well as this role here. That's what they want to check. Yeah, I don't know whether you people are understanding my question and answers or not, how much it is useful. Anyway, the next question, last question anyway. So yeah, I think I can proceed. 66 years old woman present to the emergency department with 36 hour history of increasing pedestrian palpitations. Recently completed a course of antibiotics for a chest infection. She denied any chest pain. She is a current smoker and has a 45 years smoking history. Blood pressure is on the lower side, tachycardia, saturation is maintained at 2% room air, hyperexpanded chest, which means throughout she appeared euthyroid. So, what is the diagnosis here? Go through the ECG, tell me the diagnosis. I know the diagnosis is not that difficult, but yeah, just go through the diagnosis. It's the last question anyway, so take your time. Last question for the day, not the last question. Okay. So what does the ECG show? The ECG shows that there is an AF, right? I hope the AF is quite clear. You see, it's an irregularly irregular. Irregularly irregular pulse rate. So based upon that, we can show that it's an AF and the patient is hemodynamically unstable. BP is low, tachycardia is there. So basically, again, a management of AF. So the first option, antibiotics, really not the answer. Anticoagulation and delay rhythm control for 3 weeks. If we come back to this, rate control, with calcium blocker, beta catecholamine blocker. Option is rhythm control with heparin cover. So rate versus rhythm control, there is not much difference usually. But because here the patient is hemodynamically unstable, so the patient really needs to be electrically cardioverted, right? So rhythm control is the answer here. It's heparin covered because obviously the patient is at a high risk for embolisms, and so an anticoagulation is given. Heparin or prednisone or anything, but anticoagulation is given. So option B is only anticoagulation and delay rhythm control for 3 weeks. So in a hemodynamically unstable patient, you don't do that. Okay, right? So you have to get with a rhythm control either by chemical cardioversion or by electrical cardioversion. And that's what they are checking here. Okay, so there is another question. Yeah. So what are the diagnosis here? Fever, malaise, history of PDA closure, flushed, pulse rate is 95, generalized muscle tenderness, red painless spots, signs of recent weight loss, no cardiac murmurs. So what is the diagnosis? Because it's a cardiology class, so the diagnosis is obvious infective endocarditis. But believe me, in an exam, they will give an eye case and it will be a bit difficult diagnosis because they have written that no cardiac murmurs were had. But as you know, there can be, reduced criteria says that there can be two major criteria, all five minor criteria, or one major, three minor criteria, right? So the patient can have the blood culture showing oxygen quantity. So one major criteria definitely fail. No cardiac murmurs, but we also include echocardiography to look at the vegetations and the regurgitations and those things. So that is not there. And the patient has pyrexia, patient has got these palmar spots, and the patient has got a high CRP. So the three minor criteria fulfill. So the patient is fulfilling the those criteria for infective endocarditis. The diagnosis is infective endocarditis. So the answer is option E. Because the diagnostic criteria, the disease criteria have been met, so treatment should be started. You should not wait for the blood cultures or the transport echocardiogram. So it's a very important question. You have to know the diagnostic those criteria, and you also have to know the minor criteria also, right? Both the major criteria and all the minor criteria have to know. And on the basis of that, only you can diagnose this patient as an IE, and you can go for option E. Otherwise, it is easy to go for the blood cultures or the echocardiogram first. But here, those things are not required immediately. You can start the treatment and then go for an echocardiogram. Guys, that was the last question of the day. Okay, and I hope that this will be an interactive session. But I don't know. And two questions I think others have answered, but yeah. I think as we move forward in this edit course, I think do more of these MCQ classes. I think more of the will join. Usually it's a didactic lecture, right? I tell or the other faculty tell and you guys listen, and that's also needed. But I believe that because of experience with MCQs is also needed. That's why I did this class and do practice MCQs because studying theory is not enough to pass the edit part one. Edit part one is not that difficult. It's just to practice the MCQs from Bennington, from Google's, from this accuracy books. There are three, four books that I think you guys know. So yeah, just practice the MCQs. Theoretic classes also do definitely. Yeah. I think people are already listening. They don't want to listen what I want to tell. So, yeah, but I'm okay. That's fine. But yeah, I hope that if you guys have any doubt, just contact the First Academy and they can share your doubts with me and I will be happy to answer. And see you in the next class, whatever the place. Goodbye. Good night. Have a good evening. Yeah, do go to infective endocarditis, atrial fibrillation, MR and MS indications, and the cardiology MCQ indicator because there will be cardiology has got around 35% questions in 80 part 1. Okay, so yeah.